None of the producers have any financial interest in the products or procedures shown. Pre-Decimet's endothelial keratoplasty, a new technique for endothelial keratoplasty. Corneal transplantation for endothelial decompensation is shifting predominantly to endothelial keratoplasty. DSEK has become very popular mainly because of the ability to procure prepared tissue from eye banks. However, Decimet's membrane endothelial keratoplasty, though with specific advantages, is not yet widely practiced. Difficulty in graft preparation, challenging nature of surgery, and inability to harvest grafts from young donor corneas are disadvantages of DMEK. Hyperopization, interface haze, and difficult graft preparation are disadvantages of DSEK. We describe a new technique called Pre-Decimet's endothelial keratoplasty, which combines many of the advantages of DSEK and DMEK while avoiding their many individual disadvantages. To better understand, let us take a relook at corneal anatomy. A distinct pre-Decimet's layer of tissue, the Duas layer, was described in 2007. Unlike DMEK, where only the Decimet's membrane and donor endothelium are transplanted, PDEC additionally includes the pre-Decimet's layer in the graft. When air is slowly injected with a 30-gauge needle attached to a 5 ml syringe inserted from the limbus into superficial mid-peripheral stroma, it can form either a type 1 or type 2 big bubble. Type 1 big bubble is a PDEC graft. It is a well-circumscribed, central, dome-shaped elevation measuring 7 to 8.5 mm in diameter. Type 2 big bubble is a DMEK graft. It is larger and extends from the periphery. The bursting pressure of the PDEC graft is higher than that of DMEK graft thus prepared. The Decimet's membrane can be peeled off, a type 1 bubble, without the bubble collapsing, proving the inclusion of the pre-Decimet's layer in the PDEC graft. Sometimes a combination of type 1 and type 2 bubble may be obtained. The pre-Decimet's layer provides additional splintage and makes the graft more robust and resistant to tears. Creation of the type 1 big bubble is very similar to the Anwar's big bubble created for DALK, except that air is injected from the endothelial side. Once a type 1 bubble is obtained, further expansion may also be done with viscoelastic. Harvesting the PDEC graft is easy and can be done in donor corneas of any age. After achieving a type 1 big bubble, the donor graft is trephined along the margins of the bubble. The bubble is pierced at the extreme periphery and trypan blue injected into the bubble to stain the graft. The PDEC graft is then cut around the trephine mark with a pair of Vannas scissors and placed in the tissue culture medium. A blunt trephine is used to mark an area, the AC is entered, and the host Decimet's membrane is scored, stripped, and removed. The injector is then prepared by removing the spring. The PDEC graft is stained and loaded facing upwards into a cartridge. The graft is then injected into the AC. The incision is sutured and graft orientation is confirmed. It is unrolled using short bursts of fluid. The graft is then centered and air injected under the graft to float it up against the overlying stroma. Endo-illuminator assisted DMEK, or the EDMEK technique, which has been described previously by us, can be translated into PDEC surgery as endo-illuminator assisted PDEC or the EPDEC technique. EDMEK or EPDEC achieves excellent visibility even through hazy corneas and allows better three-dimensional comprehension of graft morphology, orientation and dynamics, as well as enhanced depth perception. Entire extent of the graft is seen even if the dye has faded. In our experience, the PDEC graft, with its relative rigidity and toughness, allows easy intraoperative handling and insertion of the tissue, as it is not as flimsy and does not tear as easily as the Descemet's membrane alone. We have also combined PDEC with glued IOL in patients with pseudophakic bullous keratopathy and inadequate sulcus. After implanting the glued IOL, a test of AC stability is done by injecting an air bubble. If air is seen to go posteriorly, pupilloplasty is done before performing the PDEC. It is important to have a stable IOL iris diaphragm in order to achieve a stable air fill at the end of PDEC. The same is also applicable for DMEC. When oriented correctly with endothelium facing posteriorly, the edges of the graft should be curled upwards. E-PDEC generally confirms this beyond doubt. The graft is unrolled as usual and floated up. Any folds in the graft can be straightened by using a reverse Sinskey hook carefully at the extreme edges of the graft. The tougher nature of the PDEC graft easily allows proper centration without causing tears in the graft, as may occur with a DMEC graft. Air is filled in the AC and the scleral flaps and conjunctiva sealed. Post-operatively, the cornea is seen to clear and the graft is seen to dehydrate slightly over time. A PDEC or DMEC graft should never be injected without adequate iris IOL support to avoid a drop into the vitreous. Phacoemulsification may be combined with PDEC in Fuchs dystrophy with cataract quite successfully. The host Descemet's membrane is stripped and removed. The graft is then injected into the AC, oriented, unrolled and floated against the stroma with an air bubble. We have been able to successfully perform PDEC with a donor graft of 1 year. This allows the ability to transplant even young donor tissue, which is at present difficult with DMEC because of greater difficulty in graft harvesting. Spectral domain optical coherence tomography in vivo analysis of PDEC grafts showed mean graft thickness after 1 month to be approximately 25 microns, which is thicker than the conventional DMEC graft, but less than the ultra-thin Descemet's stripping automated endothelial keratoplasty graft. If a PDEC bubble is not obtained, surgery may still be continued by harvesting a DMEC graft. To conclude, PDEC provides benefits of DMEC such as speedy visual recovery while overcoming many of its disadvantages. PDEC takes ultra-thin DSEC to a thinner level, retaining its advantages.